Imagine, just for a second, a medical technology so smart it could perfectly tailor breathing support for someone critically ill. Really intuitive, right? Promising faster recovery. Sounds amazing, like the future of ICU care, especially now with all this talk about smarter tech. But here's the twist, and honestly, it's kind of the letdown from this deep dive you shared. After this huge, decade-long international study, this smarter way, it was, well, no better than the standard approach for getting patients breathing on their own again. We're diving into the PROMIZING trial today. It looked at proportional assist ventilation, PAV plus MAIR versus the usual pressure support ventilation, or PSV, and the headline right up front. PAV plus didn't get people off the ventilator faster, not even a little bit. It was a really solid negative result from a top-notch study. So the big question is, why? Why didn't the seemingly smarter tech actually win out?
Yeah, it really makes you think, doesn't it, that theoretical cleverness doesn't always, automatically work out in the real world, in the clinic. And PAV Plus does sound good on paper, unlike PSV, which just gives a set pressure boost.
Right, like a fixed amount of help.
Exactly. PAV Plus measures the patient's own effort, their lung stiffness, airway resistance, all that, breath by breath. And it adjusts the support proportionally. The whole idea is to sync better with the patient, maybe keep their breathing muscles stronger.
Looking at the paper you sent on this trial, the scale is just massive. This wasn't some small side project.
Yeah, not at all.
Investigator-initiated, randomized, open-label, 23 centers, 7 different countries: Canada, France, Italy, Spain.
That's right. And that widespread means the results are pretty generalizable if it didn't show a benefit across all those places.
That probably wouldn't elsewhere either.
And think about the time commitment. 11 years total. 7 of those just enrolling patients. They got, 573 adults, all critically ill, on vents, needing support, but potentially getting closer to weaning.
11 years. I mean, that kind of effort, that tells you they were serious about finding even a small difference if one existed. They randomized them, PAV plus or PSV, followed them really closely, and I saw in the methods they used intention to treat analysis.
Yes, that's absolutely key. Intention to treat. It means you analyze patients based on the group they were first put in, no matter what happened later, even if they had to switch modes for clinical reasons, which, happens all the time.
Right, reality interferes.
Exactly. So it prevents bias, stops the technology looking better than it performs when things get messy, which they often do in the ICU. It really reflects clinical practice.
Okay, so we have this physiologically promising idea, PAV plus MAC. We have this incredibly rigorous, long, expensive trial. So where did it go wrong? Or maybe not wrong. But why didn't the promise translate? The sources you sent seem to point pretty clearly at the real-world hurdles, the practical stuff.
That's where the complexity really starts to bite, I think. PAV plus. It's not just, plug it in and go. It needs about 15 breaths, give or take, for the ventilator's algorithm to sort of learn the patient's mechanic.
15 breaths to adapt.
Yeah. So if a patient's breathing is really unstable, or they have issues like severe dynamic hyperinflation where they can't breathe out fully, PAV plus can struggle.
Okay, that's the patient side. But what about the equipment? Our notes mention that too.
Definitely a factor. You pretty much need specific ventilators, those Medtronic PB840s or 980s.
So not just any vent will do. And those are expensive machines.
They are. That's a big capital cost for hospitals, many of which are already stretched financially.
So cost is one barrier.
A significant one. But maybe even bigger, honestly, is the human factor, the training involved.
Right, the sources really highlighted that.
Implementing PAV Plus isn't just a quick memo. It needs intensive, coordinated training for everyone: nurses, doctors, respiratory therapists. We're talking months. Like 3 to 6 months typically, just to get it rolled out across a unit, and maybe 6 to 12 months for staff to feel really comfortable, really proficient with it.
A whole year.
Potentially, yeah. To get good at picking the right patients, setting it up correctly, monitoring, troubleshooting all the tricky interactions that can happen.
Wow. You picture a busy ICU, things are hectic. Trying to master something that nuanced under pressure, it sounds incredibly challenging.
It is. So the theoretical smartness of PAV plus, that breath-by-breath adjustment, it seems like it got bogged down by the sheer, friction of it all.
The complexity, the cost, the huge training curve needed to make it work reliably in a busy unit.
Precisely. Which brings us back to that core finding from the PROMIZING trial and the commentary around it. Despite the elegant theory, despite the huge effort, PAV Plus just didn't beat standard PSV for getting people breathing on their own faster.
And the why seems less about the tech being fundamentally flawed.
And more about the massive practical challenges of actually using a complex system effectively in that chaotic ICU environment.
So we've gone from this exciting idea of smarter breathing through this incredibly thorough test, hit this definitive negative result, and landed back at these very real, very human challenges: cost, equipment, training.
It really forces you to look at that gap between what should work in theory, maybe in a lab, and what actually works day to day in a busy hospital. Especially now, when we're all excited about AI and intelligent machines in medicine, this trial is maybe a bit of a reality check.
Cautionary tale, perhaps.
You could say that. It shows that the practical stuff, cost, access, and especially the burden on the frontline staff might be the real bottleneck for even the most advanced sounding tech.
Which leaves us, and you listening, with this final thought to Taiwan. Does the sheer complexity and the resource drain of a supposedly smarter medical technology almost doomed it from the start in busy real-world settings? Does that complexity itself limit its chance to prove effective no matter how good the theory is?
Is that friction of implementation just the unavoidable hidden cost? Something to think about.